Good afternoon, everyone, and Happy New Year. I hope you've enjoyed the holidays. We are back for serious business. As you know, my name is MARYAM. I'll continue from where we've had only one class on endocrine physiology, endocrine MEDSURG, sorry, and we started talking about overview of the endocrine system. And as we all know, the disorders of the endocrine system usually cycle around either hypersecretion or hyposecretion of any of the hormones by the glands. The endocrine system is composed of several glands. We have the pituitary gland, the thyroid gland, the parathyroid gland, the adrenal gland, the pancreatic islets, the ovaries, the testes. And all these organs, the glands, they have their function. Unlike the exocrine glands, most hormones secreted from these endocrine glands are released directly into the bloodstream. And the exocrine glands, example of exocrine gland, we have the sweat glands, which secrete their product through duct into the epithelial surface or into the GI tract. But endocrine glands, they secrete directly into the bloodstream. So we also talked about function and regulation of this hormone. We talked about the positive feedback mechanism and the negative feedback. Negative feedback is when the hormone level is concentration is low, the production is stimulated. Positive feedback is when the production of the hormone increases, then there's inhibition from the production of that hormone. So today we're going to continue with assessment of patients with endocrine disorders. And under assessment, mainly what you do under assessment is you gather information. Just like I said, endocrine dysfunction may be the result of hypersecretion or hyposecretion of these hormones. And the onset of this symptom, usually for specific disorders, is usually insidious, and they produce usually subtle or vague symptoms that are either attributed to physiologic or psychologic causes. But consequently, patients with endocrine dysfunction, they are usually labeled as depressed, malingering, apathetic, or neurotic. But in other instances, for example, in late stages of endocrine dysfunction, the patient usually seen with symptoms that are usually life-threatening. So those symptoms that are usually labeled as depressing, malingering, are usually overwhelming and they are ignored. But those are symptoms that we need to look at. So under assessment, we have the subjective data. You get data subjectively and objectively. The subjective data, these are information that are obtained from the patient and they usually provide clues as to the functioning of the endocrine system. If information cannot be gotten from the patient due to their mental acuity, which is compromised, it can be gotten thoroughly from the family member. The objective data, most of these endocrine glands under objective data, they are the ones the healthcare professional uses all their senses to get. So most endocrine glands are glands that are inaccessible to direct examination. We have to indirectly assess them. So the assessment is usually accomplished using objective data, which include physical examination and diagnostic tests. So those are basically the two things you do under objective data. You do physical examination and you run diagnostic tests. Under the physical examination, you do head to toe general examination, followed by a full set of vital signs. So variations in vital signs like temperature, tachycardia, bradycardia, they are usually seen and they are usually related to many endocrine related problems. So assessment, after that, you do head-to-toe assessment of the endocrine history of growth and development, which is very important, weight distribution and changes. Comparison of these factors with normal findings will help to give a clue as to where the problem lies. Then under the diagnostic study, the selection of diagnostic study is usually pertinent and guided from the history and the physical examination. So it is done systematically. You get your subjective data, you take your you take your objective data, then you go ahead, follow it up with diagnostic tests, which are usually related to what you've gotten. The laboratory test that you do is usually direct measurement of the hormone level. Just like I said, one classical feature of endocrine glands is they secrete directly into the bloodstream. So you just take sample of that blood and measure the hormone level, either the blood or the urine. So we won't waste much time there. We'll go directly into the disorders of the endocrine system. And the first gland we are going to pick is the pancreas. Let's remember what the pancreas is. The pancreas, as we know, is a long, slender gland which usually lies behind the stomach in front of the first and second lumbar vertebra. It consists of a head, a body, and a tail. The anterior surface of the pancreas is usually covered by the peritoneum and usually contains lobes and lobules. The pancreatic duct usually extends along the gland and enters into the duodenum. So you can see how the pancreas is related to duodenum. So we can say that anything that will affect the duodenum can also affect the pancreas through a common, that particular structure that connects the two of them is called the common bile duct. And as we know, the pancreas has both endocrine and exocrine function. The exocrine function really contributes to digestion through the production and release of enzymes. The endocrine function occurs in the islet of Langerhans, and it has several cells. It has the beta cells. The beta cells are responsible for producing insulin and inulin. It has alpha cells, which produces the glucagon. It has the delta cells, which secretes or produces the somatostatin. Then we have what we call the F cells. They produce pancreatic polypeptide, which is very vital in digestion. So the first disorder we have here is the acute pancreatitis. From the word acute, anything that has itis, as we all know, is inflammation. So it is safe to say that acute pancreatitis is an acute inflammation of the pancreas. But the degree inflammation here usually ranges from mild edema to severe hemorrhagic necrosis. So it starts at the mild edematous. The pancreas become mildly edematous. And most times when it is not managed, it progresses to severe hemorrhagic necrosis. And the main mechanism behind this is usually autodigestion. Acute pancreatitis epidemiologically is something that occurs in middle-aged women and men. But what are the etiology of this problem? The first etiology we have here is the gallbladder disease, gallstones, which is more common in women. Then we have chronic alcohol intake, which is more common in men. Not saying that it does not occur in women, but it is more common in men. Also the gallbladder disease, which is more common in women, but also occurs in men. Then we have smoking, but smoking per se is like an independent risk factor. Then we have biliary sludge, or you can call it microlithiasis, when there is mixture of cholesterol crystals and calcium salts. These are the most common causes or etiology of acute pancreatitis. Then we have less common causes of acute. They include trauma. This trauma can be due to post-surgical. During surgery, there is accidental injury to the pancreas or structures that are related to it. Then abdominal trauma. We have viral infections like HIV, mumps, Coxsackie virus. We have penetrating duodenal ulcer. You can see how the duodenum connected by the common bile duct to the pancreas. When there is problem with the duodenum, usually affects the pancreas. Then we have cysts, we have abscesses, we have cystic fibrosis, Kaposi sarcoma. Then we also have some certain drugs. For example, corticosteroids, thiazide diuretics, oral contraceptives, sulfonamides. All these are things that can cause acute pancreatitis. Pancreatitis can also occur after surgical procedures on the pancreas, like the stomach. It can occur on the pancreas, on the stomach, the duodenum, or biliary tract. Now, the pathogenesis, like I said from the introduction, the main pathogenesis, the main pathogenic mechanism of acute pancreatitis is autodigestion of the pancreas. The pancreas digests itself. And how does this happen? The etiological factor, which any of them that I've listed above, any of them, let's take for example the gallstones. What happens is when there's a blockage, it usually injures these pancreatic cells. It can either injure the pancreatic cells or the exocrine function. These cells that produce this enzyme that help in digestion. The normal thing is when these enzymes are produced, they are activated outside the pancreas. But when there is injury to the pancreatic cells, they usually activated inside the pancreas. And as we know, this enzyme, they digest. So when they are activated in the pancreas, they see the pancreas as something they can just digest, and they start digesting the pancreas rather than go inside the intestine to do that. And after that, this can also be due to reflux of bile acid into the pancreatic duct through an opening or distended sphincter of Odine. This reflux can either be caused by blockage, like I said, this can be created by gallstones, or obstruction of pancreatic ducts, which results in pancreatic ischemia. Let's take, for example, trypsinogen. Trypsinogen is an inactive proteolytic enzyme which is produced by the pancreas after it is released into the small intestine via the pancreatic duct. In the intestine, the normal thing is for it to go into the intestine and be activated to become trypsin. And that activation is usually done by what we call the enterokinase. But when there is injury to the pancreatic cells, it becomes activated inside the pancreas and digests the pancreas. So this activated trypsin in the pancreas usually digests the pancreas and causes bleeding, and that bleeding is what is called the severe hemorrhagic necrosis. Now, what is the clinical manifestation of this problem? The first classical sign is abdominal pain, and this pain is usually due to distension of the pancreas and the irritation around the peritoneum. As we know, the location of the pancreas to the peritoneum, it irritates the peritoneum, and there is now obstruction of the biliary tract. This pain is usually felt at the left upper quadrant, but it can also be felt in the mid epigastrium, and it is radiated to the back because of that retroperitoneal irritation and location of the pancreas. Other clinical manifestations include nausea and vomiting. We have low-grade fever. We have leukocytosis in case of infection. If the etiological factor is an infection, you should expect leukocytosis, low-grade fever. Then we also have hypotension, and that is why under your assessment on vital signs, this is what you're expecting: hypotension. There's tachycardia. Of course, if there's fever, you should be expecting tachycardia. Then jaundice is another symptom that can occur, clinical manifestation. Then, of course, if there's abdominal pain, which is due to distension of the pancreas, you should also expect abdominal tenderness. The peritoneum is already irritated, so the abdomen will be tender. Then shock is another thing that can occur. What are now the complications of this problem, this condition, the acute pancreatitis? We have what we call local complication and severe systemic complication. But all of these complications and the severity of the disease usually according to the extent of pancreatic destruction. How has the pancreatic cells been destroyed? Some patients usually recover completely from this condition. Some will usually have recurring attack, and others can progress and become chronic pancreatitis. As we know, acute pancreatitis is usually a life-threatening disorder when it is not managed adequately. So the two significant local complications of acute pancreatitis is pseudocyst and abscess. A pseudocyst is when there is accumulation of fluid, there is pancreatic enzyme, tissue debris, and inflammatory exudates which are surrounded by a wall inside the pancreas. So manifestation of pseudocysts can be abdominal pain, palpable epigastric mass. You palpate the abdomen and there is palpable epigastric mass, nausea, vomiting, and anorexia. And what do you think will cause the anorexia? Those enzymes that are supposed to digest, they are not there. So there's no appetite to even eat, because once you eat, there's nothing to digest it. Then pancreatic abscess is collection of pus. So you can differentiate a pseudocyst and an abscess. A pseudocyst is when there's accumulation of fluid, debris, enzymes, but abscess is solely collection of pus, and this usually results from extensive necrosis in the pancreas. It can become infected or perforate into adjacent organs. So manifestation of an abscess usually includes upper abdominal pain, abdominal mass, high fever, and leukocytosis. Pancreatic abscess require prompt surgical drainage to prevent sepsis. The main systemic complication, we've talked about the local complication, there are just two: the pseudocyst and the abscess, that is the pancreatic abscess. And we've said that the pseudocyst is accumulation of fluid, tissue debris, enzymes, and other things. But when you're talking about the abscess, solely collection of pus. So the main systemic complication of acute pancreatitis, we have the pulmonary and cardiovascular complication. Pulmonary complication can include pleural effusion, atelectasis, that is lung collapse, there's pneumonia, there's acute respiratory distress syndrome, that is ARDS. Then the cardiovascular complication is hypotension, and you know how dangerous hypotension is. It can lead to shock. Then complications, we have other complications. Tetany, which is usually caused by hypocalcemia. So what are the diagnostic studies you can order for this kind of problem? The primary diagnostic test for acute pancreatitis, you measure the hormone level in the blood. That is the amylase and the lipase, the serum amylase and the lipase. When you say serum, it has to do with blood. So apart from that, you can order an abdominal ultrasound, you can order X-ray, contrast enhanced CT scan. It can be used to identify this pancreatic. This one, I'm just using it to check the size of this. So medical management, the goal of collaborative care, the first thing is relieve pain. Like I said, the number one classical symptom is pain. So you relieve pain, prevention or alleviation of shock, you reduce pancreatic secretion. And how do you reduce that? You redirect fluid intake, correction of fluid and electrolytes, because there will be fluid and electrolyte imbalance, prevention and treatment of infection. If that is the etiological factor, then you remove the precipitating cause if it is known, that is, if it is possible. We also have surgical therapy. When acute pancreatitis is usually related to gallstones, you perform what we call ERCP, that is endoscopic retrograde cholangiopancreatography, to remove that. That is severing of the muscle layer of the sphincter of Oddi. This can also be followed by laparoscopic cholecystectomy. Then we also have drug therapy. Several different drugs can be used to treat this problem. I've outlined them. We have pain medication. We have, you put the patient on nail per oral with NG tube to suction. You give albumin if there is shock. You give IV calcium gluconate. That is if tetany is present. As I've said, tetany is something that is caused by hypocalcemia. Lactated ringer solution is the fluid of choice. Then proton pump inhibitors if it is caused by an ulcer, you give PPIs. Example of PPIs, we all know the common one, omeprazole, rabeprazole, and so. Then antibiotics, if infection, there is presence of infection. So nursing management, you use your nursing process to manage this patient. You do your assessment. We've talked about assessment. Your diagnosis. Diagnosis can vary, but not limited. We have acute pain, which is usually the first diagnosis related to distension of pancreas. It can be peritoneal irritation, obstruction of biliary tract, and ineffective pain and comfort measures. Another nursing diagnosis can be deficient fluid volume, related to nausea, vomiting, restricted oral intake, and fluid shift into retroperitoneal space. We also have imbalanced nutrition, less than body requirement, because there is weight loss. Anorexia is something that can lead to weight loss. Then under your planning, the overall goal of planning should be that the patient will have relief of pain, if the patient will have normal fluid and electrolyte balance. When you want to draw out, after you make your assessment, from that place you make your goal. You already have your goal. Your nursing diagnosis, your planning should be towards that nursing diagnosis. So the first nursing diagnosis I mentioned is acute pain. That means there should be relief of pain. The second nursing diagnosis I mentioned is deficient fluid volume. That means our second goal or planning should be normal fluid and electrolyte balance. Then we also have imbalanced nutrition.